Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into something that, well, really affects a lot of our hospitalized patients. Contrast-Induced Nephropathy, or CIN. It's a major player in hospital-acquired acute kidney injury, and it's particularly relevant for those high-risk patients needing complex scans or procedures.
It really is, and it's crucial because while the outcomes can be quite severe, the risk itself is something we can often modify quite significantly. So our clinical mission today for you is to go beyond just the basics. We want to unpack the latest thinking on risk stratification, get into the nitty-gritty of the pathophysiology, and really look at the evidence for prevention strategies. The aim is to give you solid, actionable knowledge you can use to minimize the morbidity and, frankly, the mortality tied to CIN.
Absolutely. And we've pulled together key sources, things like the kidney disease, improving global outcomes, the KDIGO guidelines, and some important clinical reviews from the NEJM. We want to synthesize a clear, protocol-driven approach because CIN is common, and the goal has to be ensuring every patient getting contrast has had that rigorous check for risk and gets the right prophylaxis.
Okay, let's start with defining the injury itself. There's been a bit of a shift in terminology, hasn't there? We have the classic definition, but also newer criteria. Can you break those down for us?
Yes, exactly. There are sort of two main definitions you'll encounter. The classic one, the CIN definition, often used historically, especially in older cardiology trials, is probably familiar to many. That's an acute rise in the serum creatinine, the SCR, of 0.5 milligrams per deciliter or more, or alternatively a 25% or greater increase from the patient's baseline value. And the key timing here is that this happens within 24 to 72 hours after they've received that iodinated contrast. It's very tied to the exposure event. Right, that 0.5 absolute number is pretty straightforward. But the newer standard, the KDIGO AKI criteria, seems aimed at catching maybe milder injuries that still matter.
That's the idea. The broader standard comes from KDIGO, and it's really about standardizing how we define all acute kidney injury, whatever the cause. So under KDIGO, it's a rise in SCR by 0.3 milligrams per deciliter or more within a 48-hour window. That's a more sensitive threshold. Or alternatively, it could be a rise to 1.5 times the baseline value or more within 7 days. And crucially, KDIGO also includes urine output criteria specifically, urine output less than 0.5 milliliters per kilogram per hour for at least 6 consecutive hours.
Okay, so it's broader. It captures more events.
It does. And the implication is significant because using the KDIGO criteria means we identify a larger group of patients, including those with what might seem like smaller creatinine bumps. But the data increasingly shows that even these smaller changes carry real long-term prognostic weight. They aren't insignificant.
That's a really important point. We might be flagging events now that perhaps we wouldn't have focused on as much before, but regardless of which definition we use, that 0.5 or the 0.3, making the actual clinical diagnosis of CIN requires something else first, doesn't it?
Absolutely critical. It must be a diagnosis of exclusion. That's the core principle. When a patient develops AKI after getting contrast, yes, the contrast is often the prime suspect. But it might not be the actual cause, or at least not the only cause. You have to systematically rule out other potential culprits common in hospitalized patients, especially sick ones. Think about things like episodes of hypotension or hypoperfusion during or after the procedure. That's extremely common. And you absolutely have to scour the medication list for other nephrotoxins. Are they on NSAIDs? Aminoglycosides, amphotericin B vancomycin, the list goes on.
And particularly after intra-arterial procedures, say a cardiac cath, you also forget to consider things like atheroemboli, right? That presents differently.
Exactly. That's a mechanical complication. If you see signs like levato reticularis, maybe some eosinophils popping up after a procedure involving catheter manipulation in the aorta, you have to think about cholesterol emboli. That's a whole different pathophysiology, carries a much worse prognosis generally, and the management is completely different from CIN. So the contrast might just be coincidentally associated in time, not the primary driver.
Okay, so let's say we've done our due diligence, excluded other causes, and we're confident it's likely CIN. What's a typical clinical course we should expect? How does the creatinine usually behave?
The timeline helps confirm it. As we said, the onset is usually within that 24 to 72-hour window. The serum creatinine level typically peaks somewhere between day 2 and day 5 after the contrast exposure. And the good news is, in most cases, CIN is a non-oliguric, meaning they still make urine and reversible form of AKI. We generally expect the creatinine to start trending down and return to baseline within about 5 to 10 days.
But sometimes longer.
Yes, you should definitely counsel patients and families that recovery can sometimes take longer, maybe up to 3 weeks. This is especially true for patients who already have significant underlying chronic kidney disease.
Okay, so often reversible, but we can't just dismiss it. You mentioned it's a big contributor to hospital morbidity. Can you give us a sense of the scale of this problem?
It's significant. CIN is often cited as the third most common cause of hospital-acquired AKI overall. It accounts for roughly 11% of all cases. And this matters because even those seemingly small increases in creatinine are linked to bad outcomes. The data is pretty clear. Even a rise of just 0.25 to zero point 0.5 milligrams per deciliter is independently associated with higher risk-adjusted mortality while the patient is in the hospital. It also leads to longer hospital stays and, naturally, higher healthcare costs.
And the most feared outcome, needing dialysis. How often does that happen, and what does it mean for the patient?
Fortunately, the need for acute dialysis due to CIN is relatively infrequent. Large studies put it somewhere between 0.4% and maybe 1.7% of cases. But when a patient does progress to needing dialysis, the prognosis becomes much, much worse. Published studies show hospital mortality rates for these patients can be as high as 35%, even close to 36%. And the long-term outlook is grim too, with 2-year mortality rates sometimes exceeding 80%.
Wow, 80%. That really underscores why prevention is so critical.
It absolutely does.
Beyond the immediate hospital stay, what about long-term consequences? If a patient recovers their creatinine, are they out of the woods?
Not necessarily. We have to recognize that an episode of CIN isn't just a temporary blip for the kidneys. It significantly increases the risk that their underlying chronic kidney disease, if they have it, will progress faster. A single hit of CIN can potentially push someone from, say, CKD stage 2 to stage 3 or stage 3 to stage 4, making them more vulnerable down the line. And there's also evidence suggesting CIN is an independent risk factor for future adverse cardiovascular events, even after accounting for the procedure itself. It suggests a broader systemic insult occurred.
Okay, so it sounds like both an acute kidney problem and potentially a long-term systemic one. To prevent this effectively, we really need to understand how the contrast actually causes the damage. The NEJM review talks about a dual mechanism, direct toxicity and indirect hemodynamic effects. Let's break that down, starting with the direct injury to the kidney tubules.
Right. The direct mechanism is focused on the renal tubular epithelial cells themselves. Iodinated contrast media, especially when they reach high concentrations after being filtered by the glomerulus, are chemically toxic to these cells. This leads to a sequence of cellular damage. They lose their polarity, they can undergo programmed cell death or apoptosis, and in severe cases, you get outright cell death, necrosis of these tubular cells.
And what does that cell damage immediately do within the nephron?
When these epithelial cells get injured, they can't do their job properly, particularly transporting ions like sodium. So more sodium and chloride than usual get delivered downstream to a specific sensor in the nephron called the macula densa. This triggers something called tubuloglomerular feedback. Normally, this system helps regulate filtration, but here it gets fooled. It senses the high salt and interprets it as the kidney filtering too much, even though it's actually being damaged. In response, it sends signals to the small artery feeding the glomerulus, the afferent arterial, telling it to constrict.
So the direct cell injury actually triggers the second part of the problem, the hemodynamic changes, the vasoconstriction.
Exactly. That constriction reduces the blood flow and pressure needed for filtration, contributing to the kidney injury. And there's more. The dead and dying cells, along with proteins that might precipitate out, can physically block the tubules. This blockage increases the pressure inside the tubules, which pushes back against filtration pressure at the glomerulus, making the AKI even worse. It's a vicious cycle.
Okay, that's the direct toxicity pathway. Now, what about that second major mechanism?
Yeah.
The indirect hemodynamic effects. You mentioned vasoconstriction and hypoxia. This sounds particularly relevant for our sicker patients.
Yes, this is a really important part of the picture. Contrast agents aren't inert vasoactively. They trigger the release of several substances that affect blood vessel tone within the kidney. Key players include endothelin, which is a very potent constrictor of blood vessels, and at the same time, there's often less nitric oxide available, which is the kidney's main vasodilator. The net result is significant vasoconstriction inside the kidney, especially affecting those afferent arterioles bringing blood into the filtering units.
And why is the kidney, particularly the inner part, the medulla, so sensitive to this drop in blood flow?
The kidney structure makes it uniquely vulnerable. The inner medulla, where a lot of the crucial concentration work happens in the loops of Henle, is already working in a low oxygen environment. It's metabolically very active, but doesn't get a huge blood supply compared to the outer cortex. So when contrast causes this intrarenal vasoconstriction and blood flow drops, that medullary tissue is quickly pushed into severe hypoxia, basically starving those hardworking cells of oxygen. This leads to ischemic cell death. And if the patient already has underlying kidney disease where the medullary circulation might already be compromised, this effect is dramatically amplified.
So we've got direct cell poisoning, we've got feedback loops causing constriction, and then this profound lack of oxygen in a vulnerable part of the kidney. Are there other factors that pile on top of this?
Yes, the physical characteristics of the contrast agents themselves play a role too. They increase the viscosity or thickness of the blood. When you combine thicker blood with reduced blood flow from vasoconstriction, it really impairs flow through the tiny capillaries in the kidney. It might even promote tiny clot formation. And there's also significant oxidative stress. The cell injury and the lack of oxygen generate harmful molecules called reactive oxygen species. These cause further damage to cells and blood vessels, keeping that cycle of injury going.
Wow, okay. It really does sound like a perfect storm inside the kidney: chemical injury, flow problems, oxygen starvation, all feeding into each other. All right, if the damage mechanism is this complex storm, then risk stratification is our way of trying to predict it. Prevention really starts with identifying who's at risk before they get the contrast. Let's walk through the patient-related factors. What's the single biggest predictor?
Without a doubt, the overwhelming consensus points to pre-existing chronic kidney disease, CKD. That's the strongest independent risk factor, full stop. The risk goes up as the baseline kidney function goes down. So the lower their estimated GFR, or the higher their baseline creatinine, the higher the risk. Just to give you a sense, the risk might be less than 5% in someone with totally normal kidney function, but it can jump to over 20%, even 25% or higher in patients with severe CKD, say, an eGFR below 30.
So getting that baseline kidney function is non-negotiable.
Absolutely. You need a recent baseline SCR before any elective contrast procedure. And if they are identified as high risk based on that or other factors, that baseline ideally should be from within the last 48 hours.
We often hear CKD and diabetes mentioned together regarding CIN risk. How does diabetes fit into the picture specifically?
Diabetes is definitely important, but its role is a bit nuanced. It acts more as an amplifier of risk, especially when CKD is already present. If a patient has diabetes but their kidney function is normal, their risk is probably only slightly higher than someone without diabetes. But when diabetes coexists with any degree of CKD, what we often call diabetic nephropathy, then it significantly increases their susceptibility to CIN. The reasons are likely complex, involving underlying damage to small blood vessels in the kidney, which makes them more vulnerable to the vasoconstriction and hypoxia we talked about.
Okay. Beyond CKD and diabetes, what other patient factors should raise a red flag for us, especially considering our often complex in patients?
Advanced age is a clear one, especially being over 75. Certain comorbidities are big signals too. Congestive heart failure, particularly if it's severe like NYHA class 3 or 5, increases risk. That's partly due to potentially lower baseline renal blood flow and also because aggressively hydrating these patients can be challenging. Other things to look for include hypertension, any signs of volume depletion, maybe they've been sick, had diarrhea, or needed a bowel prep. Anemia or a low hematocrit is also associated with higher risk. Metabolic syndrome is another factor. And certain underlying conditions like multiple myeloma, which can cause protein deposition in the tubules, also increase susceptibility.
And medications.
Yeah.
Our inpatients are often on so many drugs. What's the approach there?
You have to be vigilant about concurrent nephrotoxic medications. The usual suspects need to be stopped or at least minimized, if at all possible, around the time of contrast exposure. We're talking NSAIDs, aminoglycosides, amphotericin B, certain antivirals. Taking NSAIDs, for example, blocks protective prostaglandins that help dilate the afferent arterial, making the kidney much more sensitive to the constricting effect of the contrast.
This requires really good communication between teams, making sure everyone knows to hold these meds.
Absolutely.
Now, what about the tricky one? The renin-angiotensin system blockers, the ACE inhibitors and ARBs. There seems to be ongoing discussion about holding versus continuing them. What's the current thinking?
Yeah, this is definitely a point of ongoing debate and reflects a real clinical challenge balancing different risks. Theoretically, ACE inhibitors and ARBs reduce pressure in the efferent arterial, leaving the glomerulus. Holding them might, again theoretically, prevent a sudden drop in filtration pressure right after contract. However, the evidence for routinely holding them isn't strong, and major guidelines don't universally recommend it.
Why not?
Because for many patients, especially those with significant heart failure, or maybe recovering from a recent heart attack like a STEMI, these drugs are life-saving. Withholding them could lead to acute decompensation, which might be far worse than the risk of CIN itself. So the practice varies. Many centers lean towards continuing the ACE or ARB, especially if the patient is stable on them, but pair that with really aggressive hydration and close monitoring. The key is definitely stopping the clearly unnecessary nephrotoxins.
Okay, that makes sense. Let's shift gears to the procedure-related risks now. These are things we might have more direct control over. Route of administration seems key.
Huge difference. Giving the contrast intra-arterially directly into an artery, like during a cardiac cath or peripheral angiogram, carries a significantly higher risk than just giving it intravenously for a CT scan. It's likely due to the kidney getting hit with a much higher peak concentration of contrast, even if briefly, and often these arterial procedures just require larger total volumes of contrast to get the needed images or complete the intervention.
And speaking of volume, is there a specific dose threshold we should aim to stay under?
Volume is definitely a major factor. While there isn't one magic number, the risk clearly starts to climb with larger volumes. Generally, people get concerned with total volumes over 350 milliliters, or maybe exceeding 4 milliliters per kilogram of the patient's body weight. What's particularly risky is giving repeat doses of contrast within a short time frame, say within 72 hours. The kidneys haven't had a chance to recover from the first dose. If a patient needs 2 separate contrast studies, delaying the second one, if clinically feasible, is always preferable.
And the type of contrast matters too, right? Osmolality.
Yes, absolutely. For any patient identified as high risk, we should preferentially be using either low osmolality contrast media, LOCM, or isoosmolar contrast media, IOCM. High osmolality agents, which aren't used much anymore thankfully, place a higher osmotic load on the kidney, which can worsen dehydration and potentially tubular damage. Isoosmolar agents like iodixonol have an osmolality similar to blood plasma. Theoretically, they should be gentlest. Large trials comparing them directly to low osmolar agents haven't consistently shown a huge difference in CIN rates, but for high-risk patients, isoosmolar is often the preferred choice if available.
You also mentioned the context of the procedure itself influences risk.
Definitely. The risk isn't uniform across all procedures. It seems highest during interventions for acute coronary syndromes, especially STEMI. These patients are often hemodynamically unstable, maybe volume down, need urgent procedures with potentially large contrast doses. It's a setup for trouble. On the flip side, there are procedural refinements that might help. For instance, there's growing evidence that using radial artery access for cardiac caths instead of going through the femoral artery might be associated with lower rates of AKI, especially in older adults. Less manipulation near the renal arteries might be one reason.
Okay, so we've identified the high-risk patient using all those factors. Now, the focus shifts squarely to prevention. You said there's one main strategy that stands out.
Yes, the absolute cornerstone, the single most important preventative measure, is meticulous intravenous hydration, period. No drug, no fancy supplement has ever consistently outperformed just giving the patient enough of the right IV fluid at the right time. The goals are basically to increase urine flow, to dilute the contrast as it passes through the tubules, and also to counteract the potential dehydration and vasoconstriction caused by the contrast itself.
So what's the standard evidence-based hydration protocol? What fluid, how much, and when?
The gold standard fluid is intravenous isotonic saline 0.9% ACL. That's what you'll find recommended in essentially all major guidelines, including KDIGO. For patients deemed at risk, the typical protocol is to start the isotonic saline at a rate of 1 milliliter per kilogram per hour. You want to begin this infusion 6 to 12 hours before the contrast exposure and continue it for another 6 to 12 hours after the procedure is done. This timing aims to ensure they are well hydrated and making good urine throughout that whole vulnerable period.
Now, for a while there was a lot of buzz about using sodium bicarbonate instead of saline. The idea was maybe alkalizing the urine could reduce free radical damage. Where does bicarbonate stand now?
That initial excitement about bicarbonate has largely faded based on results from large, well-conducted trials. While bicarbonate is still considered an acceptable alternative hydration fluid, major studies, like the PRESERVE trial, ultimately showed no significant benefit of bicarbonate over standard isotonic saline for preventing CIN or other adverse outcomes. So while the theory was interesting, it hasn't panned out in practice. The really key message is ensuring adequate volume expansion with an isotonic fluid is what matters most. The specific choice between saline and bicarbonate seems less critical.
What about those emergency situations, the STEMI patient going emergently to the cath lab where you don't have 6 or 12 hours beforehand? Are there faster protocols?
Yes, there are accelerated protocols for urgent situations, but you have to use them cautiously, especially in patients who might be prone to fluid overload, like those with heart failure. A common approach is to give saline at a higher rate, maybe 3 milliliters per kilogram per hour, for just 1 hour right before the contrast, and then drop back to the standard 1 milliliter per kilogram per hour for about 6 hours afterwards. Using these faster protocols requires careful judgment and very close monitoring of the patient for any signs of volume overload, like shortness of breath or crackles.
And just to be clear, can patients just drink a lot of water instead?
For high-risk patients needing significant contrast loads, relying on oral hydration alone is generally considered insufficient. The IV route ensures predictable and adequate volume expansion.
Okay, hydration is pillar one. Pillar two involves managing the contrast itself and adjusting medications. What does the procedural team need to do regarding the contrast?
The mantra has to be, use the lowest possible dose, minimize the contrast volume needed to get the necessary diagnostic information or complete the intervention. This often requires good communication between the requesting clinician and the radiology or cardiology team. And as we already discussed, they must choose the right type of agent, preferentially isoosmolar or low osmolar contrast for anyone identified as high risk. Avoid the older high osmolar agents completely.
And let's circle back to medications quickly. We know to stop the obvious nephrotoxins like NSAIDs. What's the final word on ACE inhibitors and ARBs around the procedure time?
As we touched on, it remains nuanced. While holding them might seem intuitively protective against a pressure drop in the kidney, the lack of strong evidence for benefit, combined with the potential harm of stopping vital medications in patients with heart failure or recent MI, means routine discontinuation isn't recommended by most current guidelines. The more common practice now is often to continue them, especially if the patient is stable, but to be absolutely rigorous about the IV hydration and post-procedure monitoring. The definite action is stopping non-essential nephrotoxins.
All right. What about pharmacologic adjuncts? The one we hear about most is N-acetylcysteine or NAC. It's an antioxidant. Why is the evidence still so debated?
NAC is, well, it's controversial. It's often considered mainly because it's cheap, easy to give orally, and has a very few side effects. The theory is that its antioxidant properties might help mop up those damaging reactive oxygen species produced during the injury process. However, despite decades of study and numerous trials and meta-analyses, the data supporting its effectiveness in preventing CIN remains really inconsistent and, frankly, weak, especially when compared against good hydration. So the current guideline stance is generally that NAC, usually given as 600 or 1,200 milligrams twice a day, starting before and continuing after contrast, can be considered as an adjunct. But it absolutely must supplement and never replace aggressive IV hydration. It's not a primary prevention strategy.
And other drugs that have been tried? Statins, theophylline, anything else pan out?
Unfortunately, no. Many other agents have been investigated over the years with largely disappointing results. Routine pretreatment with statins hasn't consistently shown benefit specifically for CIN prevention, although patients at risk for CIN are often on statins for other reasons anyway. Theophylline, which was thought to counteract some vasoconstriction, didn't prove effective. Phenaldipam, another vasodilator, also failed in large trials. And importantly, aggressive strategies like trying to prevent CIN by doing prophylactic hemodialysis or hemofiltration before the contrast exposure have been studied and shown not to be effective, and they carry their own risks. So those are definitely not recommended.
So the focus really stays on hydration, minimizing contrast, managing risk factors, and being careful with medications.
That's exactly right. Those are the pillars with the strongest evidence.
Okay, let's shift now. Despite our best efforts at prevention, sometimes CIN still happens, especially in those very high-risk individuals. Once we've diagnosed it at the creatinine's up, we've ruled out other causes. What's the management strategy? It sounds mainly supportive.
It is. Once CIN is established, the management is entirely supportive. There's no magic bullet to reverse it. The first and most critical step is ongoing, careful monitoring. That means tracking serum creatinine levels and paying very close attention to urine output. Is it decreasing? Is the patient becoming oliguric or even anuric? That tells you about the severity and trajectory.
And what are the core principles of that supportive care?
Maintaining hemodynamic stability is key. You want to ensure the patient is euvolemic, not overloaded, but definitely not volume depleted. Avoid any further episodes of hypotension, as that will just worsen the kidney injury, and it's absolutely crucial to avoid any further insults. That means no more nephrotoxic drugs stop NSAIDs. If they were somehow restarted, hold off on aminoglycosides, etc. And, of course, no more iodinated contrast media until the kidneys have fully recovered. If the AKI is worsening and the blood pressure allows, some clinicians might decide to hold ACE inhibitors or ARBs at this stage, if they hadn't been held earlier, to try and support glomerular filtration pressure. But again, that's a clinical judgment call based on the whole picture.
And just to be absolutely clear for everyone listening, are there any specific treatments, maybe things like diuretics or even continuing NAC, that can actually speed up the recovery process once CIN is set in?
No, that's a really important point to emphasize. There is no specific drug, not dopamine, not loop diuretics, unless needed for volume overload, not continuing NAC or bicarbonate that has been shown in good studies to accelerate renal recovery or reverse the established CIN injury. Management relies on giving the kidneys time to heal, maintaining overall patient stability, and providing supportive care while that tubular regeneration hopefully occurs.
And when does dialysis come into play?
Renal replacement therapy, or dialysis, is reserved strictly for the standard indications of severe acute kidney injury. These are things like refractory volume overload causing respiratory distress despite diuretics, severe hyperkalemia that you can't control medically, intractable metabolic acidosis, or signs of uremia like pericarditis or encephalopathy. Dialysis treats the consequences of the kidney failure. It doesn't treat the underlying CIN itself.
This really highlights the limitation of serum creatinine as our main marker, doesn't it? By the time it bumps significantly, the injury's already happened. This is where the idea of earlier biomarkers comes in.
Exactly. Creatinine is inherently a late marker of injury. It reflects the balance between muscle production and kidney excretion. For the level to rise measurably, kidney function has often already declined substantially, sometimes hours or even a day or two earlier. Some studies suggest that even very small changes, like a 5% rise from baseline seen maybe 12 hours after contrast, can predict who will go on to meet the formal CIN criteria and potentially have persistent damage. But even 12 hours is still quite delayed from the initial insult.
So what are the promising earlier biomarkers that might give us a heads up sooner, maybe even in time to intensify preventative measures?
The main ones generating interest are things like plasma or urinary NGAL, that's neutrophil gelatinase-associated lipocalin, and also serum cystatin C. NGAL, for instance, is a protein released very quickly by injured kidney tubule cells. Levels can rise in the urine or blood within just a few hours, maybe 2 to 6 hours after the initial insult. That's much faster than creatinine. There's research, for example, after cardiac procedures showing that an elevated NGAL level at 6 hours post-contrast can predict subsequent development of CI-AKI with pretty good accuracy.
That could potentially be game-changing, right? Identifying injury almost as it's happening.
That's the hope. Cystatin C is another marker. It's filtered by the kidney and less influenced by muscle mass than creatinine, making it potentially a more stable baseline marker, and it also tends to rise earlier than creatinine after injury. While these biomarkers aren't yet standard practice everywhere for routine CIN risk assessment or monitoring, they represent a potential shift towards more proactive management, identifying injury early enough to perhaps intervene more aggressively while the damage might still be evolving.
It gives us a window creatinine just doesn't offer.
Precisely.
Okay, let's bring this home. Thinking long term, even if the patient's creatinine returns completely to baseline after an episode of CIN, what's our responsibility for follow-up?
We need to ensure these patients have appropriate follow-up, especially if they had significant pre-existing CKD or a severe CIN episode. While most will recover baseline function, if the creatinine remains elevated or doesn't quite return to their known baseline, that absolutely warrants further investigation. You need to make sure another cause of AKI wasn't missed, and it's a clear indication for a nephrology consultation. And importantly, given that strong link between even seemingly recovered CIN and the long-term risks of faster CKD progression and cardiovascular problems, these patients really need ongoing monitoring of their kidney function and cardiovascular risk factors in the outpatient setting. One episode flags them for closer attention long-term.
Great. So to wrap up the key takeaways in this deep dive for you, CIN is definitely a common and potentially serious hospital complication. It's driven by that nasty combination of direct tubular toxicity and kidney vasoconstriction. But the good news is the risk is highly modifiable if we're diligent. The absolute cornerstones are meticulous risk stratification before contrast exposure, followed by dedicated intravenous hydration, primarily with isotonic saline, tailored carefully to the individual patient's risk and fluid status.
And building on that, considering how strongly even mild CIN, maybe just meeting the KDIGO creatinine criteria, is linked to poor long-term outcomes like accelerated CKD progression and those concerning mortality stats for severe cases, it really pushes us to ask a critical question for the future. Should our standard standard hospital protocols evolve, should we perhaps start universally incorporating earlier, more sensitive biomarkers like NGAL or cystatin C, not just for research, but maybe into routine clinical practice for high-risk patients? Could knowing about injury at 6 hours instead of 48 hours allow us to implement even earlier or more aggressive preventative strategies, perhaps altering hydration or other measures before significant damage is locked in? That's the direction preventative nephrology needs to explore.